basic plan is the 1,000, 3,000 PPO. As we're going to see in another slide, we're proposing to go to one plan with a deductible of $1,250 individual, so an increase of $250, and $3,750 for the family deductible. And we'll show you what that means in terms of dollars in the next slide.
Mr. Silva, you said we have 3,050 members. That's not everybody, though. That's our employees who are members in the plan. How many people do we actually insure?
Total lives, we are at about 5,000. Another one of our proposed strategies that I want to introduce to you is in our pharmacy plan. It's a federal program. It's a 340B. It's a mail order program that we can take advantage. It's a program that was designed for certain at a very low cost, and then turn around and sell them to their consumers, and be a profit margin that still allows for them to make money, but not what the retail market is costing the rest of us. So we're looking into that. It's something that we think would save us significant money without a whole lot of impact. There are some conditions to be able to use and leverage this program. There's 4 of them. As long as we meet one of those, we'll be able to take advantage of this program. That the prescription is written by a hospital for a hospital patient. Another is that the patient is a hospital employee. A third is that a prescriber is affiliated with the hospital. And the fourth is the patient has an annual telehealth visit with a hospital pharmacist. Working with our third-party administrator on our pharmacy plan, we have a solution that would leverage that fourth option, where we could redirect the 40B program, and as a result, we would be paying considerably less for these prescriptions. Now, what does that mean to the employee? To the employee, that would mean that it'd be a mail order program, and that they would have to at least annually make sure to have a telehealth visit with the vendor, which is a hospital pharmacy program. So that's the only requirement in order for all the requisites to be met. And we think that's something that we definitely want to pursue. As of current utilization, there's 42 members filling 156 prescriptions that we could redirect to this program, and potentially an annual savings of $250,000 by impacting 42 members. So we think it's relatively low impact with significant savings in dollars. So it's one that we're recommending.
On that real quick, I have a question. Now, these 42 members that you've identified, they wouldn't have to switch over to that, right?
So our recommendation is that they would.
Okay.
So this would be very similar to a mandatory mail order program.
Okay.
But very specific to the eligible drugs. This isn't all drugs. This isn't all members. It's only medications that are eligible for that 340B program. And currently, it's only 156 prescription of those 42 members. But as new prescriptions would come available, as new members start filling new prescriptions, the process would be that it'd get notified, a letter that says, on this day you need to transition it, or immediately you have to transition it. That way it'll go through the mail order program.
Thank you.
And you said it's a specific drug. Is it 1, 2, 5?
So that it's several.
Okay.
So it's all based on utilization. So it's an ongoing process with our PBM. Not everybody's impacted. Currently, it's just those 42 members. Could it grow? Yes. Could it go down? Yes. It's all based on the type of prescriptions they're filling. So it's much like our current formulary list. There'd be a formulary list of medications that would have to be run through this 340B program.
And we would make that formulary list, and then we would have a vendor?
The vendor would tell us which list it is.
Okay.
We would make that available to our employees, and then as they start filling them, they'd be notified of that program and the requirement to fill it through that mail order program.
And who would assist the employees? Because, just to get the process started with having a telehealth, conference first initially, right? One per year?
One per year.
To qualify, but would there be somebody assisting the employees to set up that telehealth?
The vendor, that would be the vendor's role.
Which is, who's our vendor?
So the vendor is, it's actually a pass-through through Araya. So Araya is our
Araya.
pharmacy benefit manager. They have already identified a group that is doing this. They have done a small pilot of their own in their group. It's been done elsewhere, but in their group, they've already done a small pilot. They're prepared to present that to us so that we can start taking advantage of it. But that vendor would take on the role of receiving the calls, sending information, make sure they're enrolled,
Okay.
and then following through for filling those prescriptions and mailing it to the members.
Do we anticipate that the employee is going to experience any difference in cost of their medication?
No, no. As a matter of fact, we're exploring, and I might turn around because I don't know if we've confirmed that this could be a potentially zero copay situation, much like our international pharmacy program, that the savings are enough where we might even say at zero cost. I don't know if the model included that in that $250,000, if I may turn around. Yeah. So yeah, they're confirming that that the modeling we did to save those $250,000 includes a zero cost copay for the employee. So they shift likely from a $25 or $45 per month retail over-the-counter copay to zero through the mail.
So that would be, it would be to also
It'd be-
beneficial to them to get it through the mail too?
It'd be a savings to them, and it'd be a savings to the fund.
I guess I'm confused on why it's only 42 members when it has to meet one of those conditions, right? And the prescriber is affiliated with the hospital. I mean, there are hundreds down here that are affiliated with one particular hospital. So I would think that that number would be more than 42. I'm surprised it's only 42.
Again, it's based on what prescriptions they're actually filling. This is actual information of who we identified so far.
Okay,
Could it be more? And moving forward, could that number grow? Yes, it can.
okay.
Yeah.
So it's based on the prescriptions that
That-
qualify?
That we,
That qualify?
correct. Based on our current utilization, looking at those medications, which ones are 340B eligible, this is what was identified.
Okay, thank you.
Not to keep on this slide, but a hospital pharmacist, who is that? That's not just a regular pharmacist, like you go to Walgreens, or you go to Lee's, or you go to, you have to go to the hospital to,
So that'd be part of what the vendor already has set up. They have that built in where they already have that vendor who, it will be a hospital-based pharmacy that they've already contracted with to provide the service. They're doing it right now, potentially, to meet their 340B requirement. We'll just be including the program for our members.
okay.
So this is on that specialty pharmacy tier that I alluded to. So this is again some other school districts and how they've been managing specialty drugs. Now, specialty drugs can be defined a lot of different ways. Sometimes it's based on conditions. Sometimes it's based on cost. Sometimes it's based on handling of the medications. There's very specific handling requirements, for shipping, those kinds of things. So not all of these school districts listed here necessarily have the same definition, but they all have a specialty tier of some sort to manage higher costing medications. Just as a few examples at the top, the first school district there has a deductible of $100 in the pharmacy plan. We currently don't have one, and a 50% copay. So just like you go to the physician and pay a copay for pharmacy on a specialty drug, there's a deductible, then it's 50% of that cost is their copay. Whatever the dollar amount is, 50% of that paid by the plan, 50% of it paid by the employee or member. Similarly, the next one under that has a similar program. It's capped at $100. That copay is 10%, but they don't have a deductible. As you can see, there's variations of that model. One particular school district there in the middle only has a copay that's different than their other standard copays, in this case $65. So it's a flat copay, but separate and apart from the generic, the brand, and the non-preferred medications. So our tiers currently, there's three, as I mentioned, $7, $50, $25, and $45. A specialty drug more than likely falls into that $45 tier. That would be the out-of-pocket expense for our employees. We're proposing putting in a specialty co-sharing tier that I'll share with you here in a future slide to to help manage those drugs. Now, it is very strategic in that it's very limited to GLP-1 medications. As it was mentioned to you all last meeting, the GLP-1 medications, in particular Mounjaro, is a pain point for the plan. It's very expensive. At least currently, it's not cost effective to source it internationally. We lose the rebate and we end up actually either barely breaking even or the savings is very little. So there's more disruption shifting them to international, so we allow it for retail. That's the drug this particular tier would target. And I'll talk more about what that means to the employee in a future slide. So rate increases. We talked about potentially it's time to do that. This particular model assumes one plan, so only one set of rates and tiers. So this is our basic plan. Currently $65 for employee only, which is our greatest population, all the way to the employee and family plan, which is $733. The enrollment you see there, the 2762, if you recall earlier, I shared with you, was 2246. So again, this assumes one plan. So those other 536 employees that were in the high plan and state plan were migrated into this plan for purposes of the illustration. And so on top of that, being one plan, this reflects a 15% increase in those basic plan rates. So a $65 employee-only rate would move by $9.75 to $74.75 per month, going down that scale. So employee and family currently $733, an increase per month of $109.95 to a new monthly rate of $842.95. Now, these rates, in terms of the high plan and state plan, they're actually lower. So employees that would migrate, those 536, would actually be paying less than what they were paying under the high plan and state plan. But the employee only that have been there all along would definitely see an increase by those numbers. Okay. So the potential strategy summarized here, the first one there is what we talked about, an employer contribution of an increase of $55 to $521.50. Pros and cons. Obviously, it's a budgeting situation. Over $2 million additional budgeting. So definitely budget considerations. It does align us closer to what other school districts are doing in terms of an employer contribution. But again, it's $2 million additional revenue that the district would have to come up to. Timeline-wise, this is a 7/1 target date. It coincides with the budget process, so it would be 7/1. The next strategy there, potential strategy, is what we talked about, the employee premium increases. Assuming the one plan, 15% across all tiers, it would bring in some additional funding, and not a whole lot, $155,000. Of course, employees are never fond of increases in their premiums, but and it impacts all members regardless of utilization. So in terms of strategies, this is one where whether you're using the plan or not, it impacts you. One note here that 15% is the cap in order for us to maintain ACA compliance on affordability. The third strategy there, 3 and 4 are related. 3 was something we talked about in years past about discontinuing one plan and moving to a 2-plan model. So discontinuing just the state plan would get us closer in terms of predictability. It would help contain the cost because that plan is definitely underfunded. And so even though there's very little enrollment, the loss ratios are very high. So something needs to be done there, either adjusting benefits, transitioning it to a one model plan, or increasing the rates. But increasing the rates to make it fund more appropriately would be astronomical, so we're not recommending that. What we are recommending is, as I said, a single plan model. That's the number 4 there. It does help us contain the cost to a tune of about $3.5 million. That we think it'll be the cost shift, the cost savings, because the other 2 plans are by far the highest loss ratios. So we wouldn't have those high loss ratios. And the basic plan has different coinsurance, so it does shift some of the coinsurances to the employee, where before they had the 20% and the 15%, now it'd be a 30% cost share. So that's why there's a pretty significant cost savings there. Again, this would be a 1/1/26 implementation, because this is a plan change, and our plan is calendar year. So this change would be January 1st of 26, unlike the budget increase would be consistent with the fiscal year. Strategy number 5 is, in addition to moving to one plan, we're recommending adjusting the deductible, going from $1,000 to $1,250. What you have there on estimated savings, ROI, are options we looked at, options we modeled. So moving from $1,000 to $1,250, $1,000 to $1,500, et cetera, that's what the potential cost savings would be, from $230,000 all the way up to just shy of $1 million if we would double the deductible. $1,250 would put us more in line with some of the other school districts and plans, so we think it's still reasonable, and that would bring in additional savings of about $230,000. Again, as I said earlier, the employee dissatisfaction with those kinds of changes, plan design changes. However, this is the kind of change that only impacts those utilizers. It doesn't impact those employees who are not using the plan, who are, for whatever reason, not had to use it. So it doesn't impact everybody.
Do we have, I'm sorry, Mr. Zola, do you have a percentage of, if we have 5,000 people on the plan, what percentage actually use it?
It's typically the same stat that we see elsewhere, like 20% of the employees are 80% of the cost, somewhere in that range.
And they're usually the ones with the higher plans, right?
Exactly. The high plan and our state plan are by far the highest loss ratios. The basic plan is actually, that's why we're proposing to move to the basic plan. At the current benefits, at the current loss ratios, it's sustaining itself. So just by doing these other adjustments, it would put us in a better position long-term. But definitely those other two plans are by far the highest loss ratios. A couple of quick notes on that one as well. It's not just deductibles. There's a couple of other recommendations, the specialist copay and adjustment to that, and adding an inpatient hospital copay, which doesn't exist currently. That is more traditional, so we've not had that. We're proposing to include that as well as a plan design change. So 3 changes: adjusting the deductible, specialty plan copay, and introducing an inpatient hospital copay. All that collectively, potentially $230,000 in savings. Item number 6 is what we discussed about the specialty tier. It's adding a 4th one based on coinsurance just for certain GLP-1 drugs, and at least currently the only one would be Mounjaro. Now, as new drugs come into the market, we expect Mounjaro to stop being as highly utilized, as we've seen the trend with Trulicity and with Ozempic. If you recall, Trulicity was first, then it was Ozempic, and then it kind of tapered off, and now it's Mounjaro. We expect that trend to continue, so we need to position the plan to be able to manage those high-cost drugs as they become available. And so putting a tier like this would put us in a better position to do that. Now, what does that mean for our utilizers, for our employees, for our members? At least currently, there's 112 members utilizing this particular medication. If we put in what we're recommending of a 30% co-share amount, that'd be about between $200 and $300 out of their pocket for those prescriptions. Now, there's programs available for that medication that many are taking advantage now anyway, and those that are not, we can make sure that they're aware that they can't. The manufacturer provides either discount cards or copay assistance programs where they might not even be currently paying that $45. They're paying $10, $15, $20. So even though we might put in a tier that when they're ringing at the pharmacy, it says $250 charge, immediately the pharmacy knows there's an adjustment they make, and the manufacturer approves it, and their copay drops significantly to as little as $10. So the impact is not going to be $200 to $300 for every employee every time, but it potentially could be. And I just want to make sure you all are aware of that this tier could potentially cost more to the employee, but a significant savings to the fund and position us better to manage those drugs moving forward.
Was that what you were referring to in the beginning, as specialty drugs?
Specialty drug, correct. Yeah, as I said, we're limiting our definition, and for this purpose, a specialty drug is GLP-1 drugs, and at least currently, it's only one, Mounjaro.
So that's specialty.
Yes. The other thing to note here is that this particular medication has been a pain point for the plan. I think that was discussed during the last meeting. So this is a recommendation that we move on this one sooner rather than later. We can make changes with 60-day notice, and on this one, we're proposing to make that effective July 1st if we can meet those 60-day notice requirement so that we can start taking advantage of those savings.
But Andy, does the pharmacies or the pharmacy, they do give those coupons and those discounts? All they have to do is go online and apply, right? It's there for everyone to take advantage of. Am I correct on that?
They're definitely available. They can go online. Sometimes you print, sometimes you take a code. But my experience in hearing from employee feedback is that they rarely have to do that. The pharmacists have the information readily available that as soon as they see something that is a higher cost out of pocket, the employee expresses some kind of reluctance, and really that much? Oh, wait a minute, there's a coupon we can apply. And then there's a code they themselves have available to key in that reduces that cost. But as I said, we would definitely be making sure that our employees are aware that those are available. We'll make it part of our education program.
Yeah, because there's coupons and discounts.
Yes. And so the next one, number 7 there, is that 340B program I mentioned. It has the potential for some disruption. Maybe somebody's not as willing to transition to the mail, but mail programs, as I said, are pretty common, so we wouldn't be out of the norm to transition some of that. It is a relatively low number of impacted members, at least currently based on utilization, and with the potential impact of some significant dollars. So this is a strategy similar to when we introduced the personal importation program. We found sources where we pay less, and then we developed a plan to migrate those employees that are filling those prescriptions to those sources. So whether it be those Canadian programs, in this case it's domestic, but it's a program designed specifically to leverage this 340B program. And again, based on the confirmation earlier, it'd be at no cost to the employee and a significant savings to the employer in terms of the cost of the drug. Again, this is a program where we would like to implement it sooner than later. Also 7-1 with 60 days notice to give the employees ample time to transition them and to get accustomed to this program.
On that one, you said they only have to go one time. Would they be required to go all the time to do the telemedicine? Like, is this for someone, I have the flu, I need to be on antibiotics, so I do telemedicine. This is for something else? Like, I don't know.
The annual requirement is specifically for that one medication. So it's very similar to when you fill a medication at the pharmacy. They'll ask you if you want to consult with the pharmacist about your medication. In some cases, they want to talk to you. In other cases, they leave it up to you. That's what this is. It is a requirement that when they fill that medication, you have to consult with the pharmacist. That's the telemedicine visit. So let's say it's drug A. So before you fill drug A, you're going to have a conversation with that pharmacist. That pharmacist is going to talk to you about drug A. Here's what it is. Here's how you take it. Don't take it with these other drugs. Are you taking any other drugs? Okay, well, make sure, take it after meals, before meals. That kind of consultation, that's the requirement.
So if I go to the doctor and they say, where do you want your prescription filled? Where do I say if I have to do it this way?
So that is all built into the program already. Wherever they decide to send it, once it gets to the pharmacy, there'll be a message that says, you have to use this program. Then one of two things happens. that pharmacy can call Araya. Araya can get all the information necessary, and then the process starts. Or that information goes back to the employee then calls Araya, and that process starts. There's several different ways that information has to get to our employee, but at the pharmacy, they're going to get a note that says, you have to fill it through this program for your plan. Similar to international. International pharmacy, there's a note that says you can't fill it retail. Has to go through a different program.
And is it sole sourcing? Is it, so, I mean, how do you know you're getting the cheapest drug? Is that Araya have an arrangement with a certain other pharmacy they're getting their money from? I mean.
So the model would be that the vendor is the one negotiating those costs. So as I mentioned, there's I was going to say a middleman, but technically Araya is the middle. There's another source that's negotiating those costs. What those costs are, how much the spread is on those medications, I couldn't tell you that it's not a transparent type arrangement. We just know that based on what the dollar amount of those costs and the analysis they did of what we would pay for it, we would see a savings.
So how would the system know I've already done my one, let's say I have 5 kids and I've gone to the doctor 5 different times, or I did my one telemedicine through the hospital pharmacist. How does, now I say, okay, I want to go to the Target pharmacy, I want to go pick it up there. How does the system know that?
So again, the requirement is to fill it through this program. So it's a continual fill. It's not a one-time fill. So you do your consultation with the pharmacist. You get it through the mail, through that program. Your refill comes through that program. You would not be able to go to the retail pharmacy and fill it on your 3rd time, for example. You're going to get the same message at the pharmacy that says you can't do that.
I'm sorry, I'm saying I have 5 kids. So I already used the telemedicine one time. Do I have to use it with all my other kids that are sick that year? Or I did it one time? Or is the system going to say, actually, you have to use it every single time?
Well, I think the answer to that is it's per medication. So it's a consultation for the member for the medication.
So every single time?
Now, because if they're minors, I think that's different.
No, but so every time if I go to the doctor 10 times in a year, I have to go through this system if we migrate to this?
One time per year per medication.
Right.
Yes.
So if I'm prescribed 5 different medications that year, let's say I go to the doctor 5 times, I'm on 5 different medications. So every time I can't go to the local pharmacist, I have to go to this pharmacist.
In that particular example, I think the answer would be yes. If it's a different medication,
Yeah.
then it'd
So
be a
it's not really one time a year.
separate consultation for that one medication, yes.
Okay,
But
so it's not
It
really.
would be highly unlikely, because consider the statistics. You're talking about 42 subscribers out of 5,000.
But I guess that's what I'm stuck with. How do you know it's only 42 prescribers?
Because we already know what medications qualify under that program, and only
Oh, okay.
42.
Because I'm like, every time I go to antibiotics, I'm going to have to go.
Out of the 5,000, if there is any of those strategies that we implement, it should be that one, because it's the least one that would at least affect the general population of our subscribers. And it has a big payout, not only for the employee, because think about it, if you have one drug and, you're paying, what is it, $45?
45 would be the,
$45 a month for that drug times 12, that's how much money the employee would save, not to mention how much the district would save. So it's kind of like an easy one to want to get on.
So it's a specific specialty drug that so far 42 of our members, okay, so it's not for every single, okay.
No, it's
That's
not
what I was
for
like, right.
no, and if I didn't make that clear,
No,
it's
I'm sure you
not every
did.
medication, at least not currently. As I had shared earlier, could that list grow based on actual utilization? Yes. But currently, based on our utilization pattern,
It's
they
one drug for
analyze the
42.
data, that's how many folks would be impacted.
Okay. Sorry.
So as far as the recommendations, that slide looks terrible. I apologize for that slide. So oh, there we go, there we go. Okay, so as far as the recommendations that I discussed, so I mentioned that the shortfall, about 4.8 million. Implementing these strategies here, the only one that's not on the list is that state plan, so the rest of them are here. So the employer contribution increase of those $55 per employer per month, as we mentioned, is about $2 million in revenue. So that reduced the shortfall to about 2.8. And so you see the pattern there of how it's impacting. Adjusting the employee rates, as I showed you earlier, by 15% in the one plan model would be a new revenue of about $155,000. Now, why is that relatively low? Because as I mentioned, we would have employees that are currently contributing more, moving into a plan where they're contributing less. And so there's actually a loss in revenue. Now, from that smaller amount, then we're adjusting at 15%, and the difference from moving from 3 to 1 plan is $155,000 new revenue. So relatively small amount of new revenue, but still it's a recommendation that, again, would put us in a better position moving forward. Keeping a single plan versus 3, that has by far the biggest potential cost savings to the plan. We estimate about $3.5 million. The benefit plan changes. So just adjusting those 3 things that I shared with you, the $1,250 deductible, the specialist copay, adjusting that, and then implementing an inpatient hospitalization, potentially $230,000 in savings. That coinsurance tier, GLP-1 specialty, potentially $278,000 in savings there, and the 340B mail program, $250,000. So with all of these potential savings and additional revenue, that would change the outlook from a shortfall of $4.8 million to an estimated projected fund balance in the black of about 1.5 for the year. Again, this assumes that everything materializes like we're projecting, but in a much better position than what we're currently at now.
Mr. Silva, I have a question
Yes.
on number 6 for the GLP-1s.
Yes.
Do we know of the population that we insure or that are covered, how many are actual employees and how many are family members that are on these medications?
So I don't have that stat with me, but that's one we can definitely get.
Yeah,
Absolutely.
I'm just curious because I know they are high dollar medications, and maybe that's something that we have a policy on regarding fully covering employee only or having a higher deductible or copay for a family member. I'm just curious to know how many of them are actual employees.
I seem to recall, and again, that we did.
Send an email
That we did.
We did.
Yeah,
Should they give us?
I think the
I was gonna
answer
say,
was the
you
majority of
gave us the
them.
answer.
The majority of them were employees, if I'm not mistaken.
He has it.
Do you have it?
He's got it.
While you're looking for that, the 2 million additional employer contribution, that comes from the general fund?
Most of it, yes,
That's 65%,
65% of it.
more or less.
Oh, yeah.
Yeah, by far, the employee,
Employee.
by
Okay.
far, yeah. So this kind of summarizes what we've been talking about. So projected cost, again, moving into this next year, 30 million against no revenue, no changes, the rebates we can count on and that shortfall, and then factoring everything we've talked about here, additional employee revenue of 155, the employer increased budget to about 2 million, so a total of 2.1 new revenue, and then the cost savings from these various plan design strategies, so total of about 4.2 million. So those two things collectively against that shortfall would put us into that positive of 1.5. And again, these are estimates and projections, and assuming, as I said, one plan, and those are the changes as noted there, some of which implementing as soon as July 1st. So beyond everything I just shared with you, there's some other things we're looking at, and there's always things we're looking at, but right now, there's some real interest from some providers to partner with us directly. What does that mean? That means that we would negotiate with them directly. The claims would not run through our TPA, whoever that might be. It would be an arrangement where we negotiate the claims, they send a bill, and we would pay it based on whatever they send, obviously with some auditing provisions to make sure that everything's in order. But it bypassing the TPA, getting stronger contracts directly. Why would they be willing to do that? TPAs negotiate globally, so one provider is getting the same contract as another. But if they come to us directly, there's more room to negotiate, and they know that we're going to promote them as our preferred provider. So probably more steerage for them, so potentially more revenue for them. So it's a win-win potentially. And so right now there's some interest from some imaging centers, a couple urgent care centers, one physical therapy provider, and at least one primary care provider that we're actively talking to. Once we establish that this is something we can definitely move into, we'll set up some kind of formal solicitation to invite them all and give everybody the opportunity, but probably with some parameters that we're going to set, whereas if you're willing to meet these things, then we're willing to talk to you. If it's one of those scenarios where they want to negotiate on their terms, probably we're fine letting them negotiate through our TPA. But if we can establish some very, very aggressive discounts that they're willing to meet, then we definitely want to talk to them about it. That could materialize into perhaps our own network, where we get enough of these providers where we have our own network of providers that we can set up and perhaps build some incentives for our employees to use them if the savings are there. Now, that's a little further down the line, but it's definitely something we're looking at actively.
Is this like what we used to have before, where there was a provider, I forgot his name, on Bicentennial?
The $5 MRIs?
No, it was like a doctor. I think it was Dr. Simpson.
We still have those.
And you
We still have those.
And that's direct with him? Okay.
So it's a direct arrangement, but it's administered through Blue Cross. So that provides some pluses and minuses. It had to be on what Blue Cross paper, so have to go through that process. It's very tedious for the groups to go through that process. So going to direct to us, it's less paperwork, more streamlined. They're more willing to do that. But it's actually 2 providers that we currently have an arrangement like that, and they still exist.
I know I said it probably 10 years ago when the old Kmart building, now it's the Spectrum building, but I used to always think that would have been a perfect healthcare facility / workout facility for our employees, where it could be like a MISD health. We have Crockett. And so I think it'd be a great opportunity if we could partner with doctors and urgent cares, imaging centers, if we had a facility where we could basically house or rent to some of these providers and have that for specifically our members and their children, because it is difficult when you're trying to find a provider on the weekend or spring break. If we had something like that, I think we have the space, and it's something that we could explore for the benefit of our staff. So.
Yes, ma'am.
Mr. Silva, on the imaging centers, I remember getting a call from staff members saying that, why did we stop doing January 1st our $5 MRIs? Why did we stop?
So that's actually not a change we made. So that other provider we alluded to on Bicentennial, they developed their own arrangement with a facility that they had a relationship with just down the road. And what they did was they partnered with them and said, we'll refer it to you, we'll run it through our plan, and it'll be the same $5. But that relationship no longer exists. So they themselves decided no longer to have that partnership. It was nothing we had ever
We didn't
introduced.
change it.
We
Okay.
introduced a primary care provider at the $5 copay for all of their services in-house. They turned around and said, you know what, imaging we can do with our partner, and so we're referring to them still under the $5. That arrangement that they have dissolved.
Okay.
So we do have the $10, we have $5 primary care that still remains, and the $10 primary care that also has imaging, so it'd be subject to that $10, and that's a facility admission, so that still exists.
Okay. Thank you.
We just need
so-
to continuously let the employees know of those
Yes, sir.
services, because
Yes,
it's
sir.
a lot of.
It's something we try and educate as much as possible through our newsletters. We send out a flyer with some information. And we include that information on there as far as where the night clinics are, for example, after-hours facilities, and these low-cost providers that benefit them and benefit us because there's some additional savings for the plan. Last couple of slides here. I just wanted to share with you because we're not closed off to the idea of an HMO. We did not introduce it as a potential strategy right now because we're going to hold back and see what our RFP process brings in. We might have some proposals that include an HMO plan, and it's something we can consider. I think it's preferable that we look at one that's already designed, one where they can tell us what the rates would be, what the benefits would be, than for us to try and develop one on our own from scratch. So it's something we'll leave open to consideration once we go through the RFP process. But just to give you some information on how they differ, I mentioned the PPO is by far the more flexible, wider network, more access to providers. HMO is more managed care. So you'd have to set up a primary care provider. You'd have to go through them to get to a specialist, unlike on a PPO. On the bright side, on the positive side, probably lower cost as compared to PPO. But you'd have to stick to the list of those providers. And more than likely, there is no out-of-network provider. So you couldn't decide to use somebody else. Otherwise, there'd be no benefit. On a PPO plan, conversely, you have out-of-network benefits. If for whatever reason your provider is not in network or you absolutely want to use an out-of-network provider, that's an option. There's still a benefit. It's a reduced benefit, but there's a benefit nonetheless. Those options would not necessarily exist in an HMO plan. So there's some pluses and minuses. If we find an HMO that we might consider, it'd probably be a scenario where we'd have a two-plan model instead of a one-plan model. We could move to a single-plan basic plan and then have an HMO. The basic plan would technically be the buy-up. The HMO would be an entry-level plan, lower cost, a little more managed care, something a little different for our employees that they may want to take advantage of, but perhaps not. It'd be something we'd have to educate on. And the last thing is to share with you requests for proposals. Our medical administration related services, that's basically our contract with Blue Cross currently. We're in our last year. So we need to go out to bids. This is a tentative timeline. We expect to put it out in the market on or about April 16th. It'll be open for 4 weeks. So close about May 14th, and we propose to award it in August. That should give us enough time to review the proposals, to start tabulating, analyzing them, ask for clarifications, best and final, perhaps interviews. The effective date is not till January, but on this timeline, it allows us to finalize everything and have everything by October 1st, which is our enrollment period, which we'd like to announce, obviously, if we're having changes, if there's new ID cards coming, those kinds of things.
And on this request for proposals that we're going to send out for the health, for the medical, and as well as the pharmacy, we don't know if we could have further savings by these third-party administrators that could offset some of the other things that we talked about, that like if they give us a lot of better discounts and savings, that means that we don't have to do some of the things that we talked about, because if we get a good third-party administrator for the medical, a good third-party administrator for the pharmacy, that could give us big savings, that means then we can offset some of the other things we talked about.
Yes, sir, but the potential, and that's definitely what we'd be looking at, is the big picture is the network savings, because that's, and network savings and in hospital specifically, that's where our biggest expenses are. So if we were to find a vendor where we see some significant reduction there, that potentially could change this whole model. There'd be potentially some cost savings built into that RFP process where we can start looking to knock off some of the other things. So absolutely, yes, sir. Same thing on the pharmacy plan. We're also in our last year, so we have to put out that to bid. We expect that in the medical one, we're going to see some models where they want to lump it together as one option. Several years back, we made a decision to bid it separately, and we've seen the best results that way. And so we're going to do that again. It gives us more flexibility, more opportunity to really manage our plan than if they come in as a bundle. So we're putting it out separately again. The timeline is very similar. It's off by a few weeks. So it's going to be a lot of work coming up to get this all done and in place for a January effective date. Now, on top of that, we also have a dental RFP. We're in our last year as well. So it's also January 1st. It does have budget implications because even though this is a fully funded dental plan, the district pays $18 per employee per month so that the employee pays zero for a basic employee-only dental plan. So in order to keep that, we're going to have to find a vendor that we can manage $18 where the cost is $18 or less. If it comes in where a basic employee-only dental rate is more than $18, then we're going to have to consider perhaps passing that on, whatever that difference is, on to the employee. So let's say it comes in at 25. The district will pay 18, the employee will start paying 7. And the timing of that, again, we're going to have to figure that out because those other two are very time-consuming, very involved, but we definitely have to throw that other one into the mix, the dental, and get it all done for January 1st.
My priority is to hopefully keep the plans, even if we stick to one, to not increase that to the employees, to try to keep it at the same. I think that would be what I would try to work on, to not increase the plans, because I would not want our employees to pay more. That would be the number one priority, is to keep them the same. So hopefully we can get some good outcomes from the proposals, and that we can have further savings there and maintain the same amounts for the plans, whether even if it's one, that they don't have to pay more out of pocket. That would be what I'm going to be working hard to see if we can keep them the same without having to have our employees put in more into their plan out of pocket. Let it come out from the third-party administrators and from other things that we can do district-wide without impacting the employees' hidden, where they can pay out of pocket more money. It's what we're trying to stay away from.
So this concludes my part. I'll be glad to take any additional questions you might have or clarify anything that wasn't clear.
Thank you.
And to conclude this budget workshop, I'm going to round it out with the legislative update. And we're focusing tonight only on the federal government. As you have heard by now, a lot of changes on the federal level impacting education. It started with the U.S. Department of Education being restructured, with nearly half of the employees being laid off. And then on March 20th, President Trump did issue the executive order directing the closure of the U.S. Department of Education, which, just to clarify that by closure, it pretty much means stripping down a lot of the work that is done there, shifting some of that to other agencies, and the majority going to the states. And in order to actually close it, it would require the support of congressional action. So the order does prohibit the use of federal funds for diversity, education, and inclusion programs, and then those supporting gender ideology. The order did ask that the Secretary of Education begin the lawful and phased transfer of the programs and functions while maintaining continuity of services such as special education. Now, there is a certain level of uncertainty with school districts here in the states, especially the state of Texas, because with all of this, there's a lot of funding that we see that is coming to us on the federal level, anywhere between 15 to 20% funding. These past couple of years, we have received a lot more because of ESSER funding, but that money funneling through the state, there may be some changes in regulations, there may be some changes in allocations, so those are things that we will have to keep an eye on and monitor. Guidance from the state and the feds as this transition occurs. So there's a bit of uncertainty surrounding that. There was an executive order that was passed, following the executive order passed, there was a continuing resolution that most federal education funding through September 30th, 2025, which provides funding for the 25-26 school year. So we know that we still have that. So our goal is to make sure that we continue to work with our federal partners and continue to draw down the funding that has been given to us in a timely manner and make sure that we monitor that. We can look at programs that might be at risk because there was a $290 million reduction. Part of the programs that could possibly be affected would be Title II, and then also Perkins CTE national programs. And so we're going to have to look at what we're doing with some of that funding, and then possibly come up with alternative solutions in case of changes that may occur. So we will continue to monitor that and provide updates as that happens. So so we have to prepare for these changes and possible allocation changes. And that is all I had on the legislative update.
So we're keeping an eye on the legislature at the state level as well as now the federal level with dissolving practically the Department of Education and shifting everything to the states, and see how that's going to impact us. We're keeping an eye on that and follow those changes, and hopefully they won't impact us, that we still get the money that we've been getting. But now instead of coming directly from the feds, it's coming from the states. And of course, that's something that we're all advocating, that we get the entitlements that we've been getting federally, that continues when they turn that over to the states.
That concludes our presentation.
Thank you, guys.
Thank you.
Good job. I think we can, like to entertain a motion to adjourn.
So moved.
Second.
I have a motion from trustee Aliceda and a second from trustee Rivera. All those in favor signify by saying aye. Aye. All those opposed signify by saying nay. Motion passes 5-0. We are adjourned at 6:40 p.m.